Thanks everyone for joining us today for the discussion of how digital technologies can help to address health inequalities. We have a really great program for you, and I'm excited to kick us off. I'm Cassie Walker. I'm a program director at the American Heart Association Center for Health Technology and Innovation. And here at the Center for Health Tech, we're focused on building and fostering relationships in health tech to develop innovative and scalable solutions toward improving cardiovascular health. So we do this by working with innovative companies to integrate the association science known as care plans into their platforms. And these care plans have actionable steps that people can take to help them work toward improving their cardiovascular health. So if you'd like to learn more about the Center for Health Tech and Innovation, please reach out to us. We'll put the email address in the chat here in a minute. Okay, so I am thrilled to be joined today by our moderator, Fran, give me a second, Ayalasomayajula. How was that? Did I get it? Okay, I did it. Thank you. President of REACH. We work closely with Fran and her organization, so excited to have you here as our moderator. Would you like to go ahead and introduce yourself and kick us off?
I'd love to do so. Thank you so much, Cassie, and thank you to everyone for participating with us today. And a great thank you to the American Heart Association and the Center for Health Information Technology and Innovation. We're really grateful to be able to be with you. As Cassie mentioned, I am Fran Ayalasomayajula. I am the president of REACH, a global social impact organization, and also the chief executive officer of RTL Innovation. To get us started on our discussion today, I want to kick us off with just by giving us a sort of a brief sort of reflection on some of the dynamics that are going on today within the healthcare sector, and really level set on some of the terminology that we're going to be utilizing throughout our conversation today, as we are going to embark upon a very lively discussion on health equity and the application of digital health technologies. And the first of which is really around this notion of social determinants of health. Oftentimes, folks have a tendency to use these sort of what we consider sort of trendy words now. For us who are public health professionals, myself, epidemiologist and public health professional, I look upon these and I see the opportunity and the application and applicability across all individuals, not just one set of individuals. So I challenge you as we begin to embark upon our dialogue today to consider this in the context of every patient that you are encountering, consider in the context of every subject that you have participating in your studies, and consider it in regards to every individual that you interact with within your communities and where you live, work, play, and play, because that's clearly what it's about. You know, in fact, clinical care itself is a major social determinant. It represents, in fact, approximately 20% of the social determinants of health. Other factors that we often emphasize are social economic, but education, environment, and behavioral and lifestyle are also key indicators. The policies, the regulations, and the practices and protocols that we establish really have a direct influence. And again, this is not on one set of individuals, but all individuals. A great example of this that I often go back to when we think about the 101s of public health is the thing about policy changes just around things like seatbelts, and how it took education and regulatory changes to actually bring us to a point where today we take it for granted. You can't imagine someone not wearing a seatbelt. That wasn't so much the case many years ago. So when we start talking about opportunities and the role of social determinants in the health of individuals, I encourage you and challenge you to think about that in the context of everyone. Equally, there's another aspect to this when we refer to social determinants, and it's one of the areas that I've been championing and we've even proposed to the United Nations, is that we begin to look at digital capability, digital capacity, as a new, or if you will, sixth determinant of health. That the idea being that technology has the opportunity, particularly when it comes to health and clinical care, to be able to really expand our ability to reach individuals in a variety of settings, and not just in a care setting. And to that extent, you may have heard some people talk about the internet or connectivity as being the sixth determiner. I would propose that we look a little deeper and that we examine that it's not just about having access to the internet, but in fact, how we interact with technology as a whole, whether it's the absence of, the utilization, even the overuse or overutilization of technology, or the inappropriate use of technology that can have a huge impact. And there's so many more. And as we dive into our conversation today, we're going to talk a lot about this. So with that, I'd like to pause and introduce our esteemed panel that I'm so grateful to have with us today. Absolutely thrilled. I first begin by introducing you to Dr. Eduardo Chavez, who is the Chief Medical Officer for Prevention at the American Heart Association. Dr. Anne-Marie Navarre, who is the Associate Professor of Medicine within cardiology at the UT Southwestern Medical Center. And Dr. Jacques Koundoudou, who is a cardiac surgeon at Beth Israel Deaconess Medical Center and faculty at Harvard School of Medicine. And with that, we'll go ahead and we'll get it kicked off. I always like to keep these sort of dynamic and interesting. So I'm going to give you a two-part question to start us off. And Jacques, I hope you don't mind. I'm going to refer to everyone by their first names, and we'll start off perhaps with you. If you could tell us a little bit about, this area that we're talking about in terms of creating for improved healthcare through the leveraging of digital health technology. How does this show up? Why is this a passion area for you? And what are some of the things that you think that we should be really considering in the context of the adoption of digital health technology solutions and the overall improvement of health and well-being, and perhaps even in addressing heart health as well?
Yeah, Fran, thank you so much for the introduction. And again, thanks to the American Heart Association for putting on this webinar. So I'll just give you a little bit of context into how I got into leveraging digital health. So my background, I originally grew up in Africa, where, clinical care and diagnostics were not as common as we find here in the US. But over the years, I've realized that technology could actually play a role in increasing access and delivery of healthcare. So a lot of my research has been focused on how do we take technology, for example, how can we get an EKG done or a cardiac ultrasound done in a remote area, and how can we share that data across to a clinician to look at the data and to make a clinical diagnosis, for example. So I've, over the last few years, I have, my research has been focused on hypertension, which is one of the areas where I think many populations suffer from hypertension. And digital health is a great tool at bridging that gap. So I initially, started working in some of those technologies, particularly in Africa, where there is not enough diagnostic care. And over the years, I've expanded that, thankfully, with the NIH, a grant that has enabled me to be able to scale that a little bit. So we're still learning. A lot of it is learning. Again, taking technology from one context and adopting it into another context has its own challenges. So it's not just one technology or one technology platform that works for everyone, but it's being able to take that technology and then adapt it to the local context or to the local environment. And I'm sure we'll be talking about some of those examples in our discussion.
Thank you so much for that, Jacques. I love the, that you bring forth the notion of this dichotomy that can exist, but that actually can create for, in many environments, sort of a leapfrogging of technology as well, if you will, and look forward to talking more about that. Let's move over to Anne. I would love for you to maybe do the same, share a little bit of, introduce yourself, a little bit about what makes you excited about this space and what you see as some of the initial opportunities and areas that you'd like to address.
Thanks, Fran. So I have two different hats that I sort of bring to this conversation. One of the hats is I'm a practicing preventive cardiologist. So I do clinical cardiology, and the last 2 years have brought really dramatic change in terms of how we reach people and how we can deliver care. 3 years ago, before COVID, telemedicine was pretty uncommon, and doctors were not familiar with it, and the people that we take care of were not familiar with it. And now it's pretty simple. It's as easy as, you know, a lot of grandparents having conversations with their grandkids over Zoom during the pandemic. Now we do that with physicians, and it's been a great way for us to reach people. I have a number of people with physical disability or challenges with access to transportation that I can see a lot more frequently and a lot more easily with telemedicine. We have to be careful. There's some challenges. We know there are internet deserts, both in urban and rural areas. But we've also seen improvements in access to data plans and smartphones. So, you know, we're seeing as smartphone plans get better, that even when people don't have access to Wi-Fi or high-speed internet, they can still have access to telemedicine. So that's one area that I'm really excited about. There's some work that needs to be done in terms of how do we make it more accessible to everybody. We don't have good translation services, so people who don't speak English it's hard for people to do telemedicine visits if the provider isn't fluent in their native language. And then a lot of the interaction that we're doing out of the health system is through the electronic health record. And although some of the patient portals are available in Spanish, they're not all available in Spanish. And even if they are, the lab results and the messages they get from the providers aren't necessarily translated. So we're doing some work here at UT Southwestern to try to expand that and you know, improve, at least for now, access to the portal in our Spanish-speaking population, both here and across the street at Parkland Hospital, where we also take care of patients. And then on the other side, I've worked with the Heart Association to develop a telemedicine-based consult program where we're using volunteer cardiologists from the Heart Association to provide consultative cardiology services to federally qualified health clinics and clinics that treat the and underinsured through a telemedicine platform. It's a program called Doctors with Heart that Cassie Walker has been the program director for as well. That was launched through the Center for Health Technology and Innovation. So I think there are ways that we can use technology to help expand, not just within health systems, but how do we get out of health systems altogether and try to increase our reach overall.
I absolutely love that, Anne, and in particular, how you're able to describe so many settings in which you're delivering care and recognizing the way that, you know, diversity shows up in all of those environments in so many ways, and how we need to take those into consideration. Dr. Eduardo Sanchez, I think I was so excited at the beginning that I think that I may have mispronounced your name, so I wanted to make sure that I corrected myself on that. Eduardo, please tell us, share a little bit about what excites you in this space and some of what you see as being some of the key implications that we need to start taking into consideration.
So thanks. And yeah, it is Sanchez. I know some Chavezes and I love them, but I'm not one of them. And I appreciate the call out. You know, I think the thing that excites me is that technology is here. And so we just got to figure out and be really thoughtful about how we use that technology, and being thoughtful about some of the things that I heard Anne talking about, some of the things I heard Jacques talking about, is not only how to use it, but how to anticipate what might be some challenges and barriers. So in the world that I'm in right now, and I came up through the federally qualified health center system. I've taken care of folks where I literally walked out of my clinical care setting, and somebody who had seen 3 hours before was still waiting for a bus, and I put them in my car and drove them home. With technology, that may not be necessary. I've taken care of patients who, when they came to visit me, the amount of time it took that homebound, bedbound person to be mobilized into an ambulance and brought to see me. And then I spent 20 minutes with them, and the amount of time it took to send them back, to get them back home. Even then, I figured out what I used to do was get in my car, make them my last visit of the day, and go to them. Well, with technology, neither of those things need to happen the way they happened 20 years ago. There are some things we need to think about, though, because if we're using technology, I heard Ann talk about this, we've got to know whether there is broadband availability. We have to know whether for our patients there's broadband affordability. And then we got to understand the degree to which digital and health technology might get in the way and needs to be supported. So one of the things that I think we've got to remind ourselves of is that high tech and high touch is not mutually exclusive, and we have to figure out how we titrate those smartly. The other thing that I think we have to always overcome is the myth that those people or those folks don't know how to use or don't want to use technology. Not true. What we need to figure out is how we engage in the conversations with the right messengers, the right messages, and the right means by which that technology can be brought to bear. So those are things that I think about. I think they're overcomeable. And it's sessions like this where we say, how do we put that technology to use in all real world experience settings that will get us to the place where we can realize some of the things that Jacques is trying to deliver more broadly, and some of the challenges or opportunities that Anne-Marie was talking about earlier.
You know, Eduardo, I love your comments. It gave me a little bit of goosebumps, in part because it took me back to, time that I used to spend with migratory farm workers, right, in the sister cities along the U.S.-Mexico border, doing a lot of need assessments, health need assessments, and then having the ability to then further that by creating for, programs that are appropriate and really took into appreciation the demands of the work environment in which they lived, and many of the other priorities that oftentimes get overlooked by those who are in the big cities or even in the suburbs. So Anne-Marie, I would love to hear from your perspective as we think about, moving care outside of the four walls of the clinical facilities. What is that? How do you think what's needed? How do you think that we need to go about the process of showing up in ways like Eduardo is describing that really ensure for sort of universal access to care?
Well, I think there's actually sort of two parts to that question. The first is, how do we get care out of the healthcare system? And, part of that is to change a little bit of our model of how care happens. It shouldn't be that you're only thinking about your blood pressure once or twice a year when you go in to see your primary doctor or your cardiologist. We need to be, enabling people to have more access to their own data, improve home blood pressure monitoring, glucose monitoring, activity tracking, all these things that can help people keep an eye on their own wellness. Part of the challenge there is reimbursement. You can't get a blood pressure cuff paid for, and $30, $35 for a blood pressure cuff may mean that people have to choose that over, healthy food for the week. And that's just not an acceptable trade-off that we should be asking our patients to make. So there's some reimbursement things that need to happen so that we can get better access to some of the tools for measurement at home. There are ways that digital technologies are helping us, keep track of those data. So some of my patients' blood pressure cuffs automatically feed into the electronic health record. Other people use digital platforms that help them monitor their blood pressure, or if they have diabetes, their insulin and their blood sugars, and can help keep them on track with adherence or suggest even changes to medications if needed. So, I think there's a role for technology in sort of helping spread out the care that we provide to our patients, in between those visits rather than just from, one visit to the next. But we have to, this is a topic that we talk about a lot at the CHTI, which we've dubbed health equity, which is how do we make sure that as we're using these technologies, that we're not making disparities worse. And we know that there are already unacceptable disparities in both the prevalence of cardiovascular disease and how well risk factors for cardiovascular disease are being treated. So this is where we start, there's a number of challenges from, reimbursement, as I mentioned, access to health insurance so that people can, afford the medications that we're recommending, the doctor visits that they may need in between. And then some, basic accessibility features like having a low bandwidth version of any app so that you don't have to be on, the highest speed internet, or thinking about people with visual impairments, making sure that we have technologies that they can interact with, that they can use, or do we have, if we're doing telemedicine, appropriate accommodations for people with hearing impairments. So, and there, I think the key is to really make sure that when we're designing programs or thinking about apps or new systems of care, that we have lots of voices at the table, because no single one of us is going to be able to think about every single possible challenge. But if we get a group of people together, including representation from the communities that we want to serve and the communities that we want to reach, that's when we have, and we hear all those voices, that's when we go, oh my gosh, I can't believe I didn't think about, people with visual impairments. Like,
Right.
oh, well, it's okay. That's why we have all of these people at the table. So, we have to think about it, but part of the way to think about it is to make sure that we have a really inclusive group of people that are weighing in as we're designing, and then we're measuring who's using our programs. Are they reaching everybody, and are we making disparities better or worse?
I love that, Anne-Marie. And as she was describing sort of those points of consideration, Jacques, I couldn't help but think about it in the context of post-operative care, right? Which I know is something that's really weighs on your mind, all the magic that happens within the theater I shouldn't call it magic, the science and the art of what you do to make patients well within the theater, to see them to then transition home, but wanting to have that reassurance that transition is a very successful one, and that they continue to progress positively along their health journey is something that weighs heavily on your mind. Can you talk to us about how then technology factors into that? What are some of the things that you're seeing, and what is some of what maybe you're not seeing that you'd like to see be taken into account as you consider making for optimal utilization of these technology solutions for all of your patient populations and not just for a few?
Thanks, Fran. I think this is a great question. So my line of work is focused on cardiovascular, so cardiac surgery, postoperatively. We know that reimbursement for complications, for example, hospitals are penalized for certain complications. So one good example is readmission for heart failure, for example. Heart failure is the #1 DRG in this country. And so, for example, if you have a heart failure patient and that patient keeps coming back to the emergency room every other week because of lack of taking their pills, or because the medication dosage is wrong, that's a penalty that the hospital has to carry. And so where technology could be helpful, for example, could be having, and some of it, we are doing it from the, as pilots, is where we give patients, as Anne-Marie mentioned, you give them a blood pressure kit, you give them a weighing scale, you give them an oxygen measuring device, and you connect them to the nurse practitioner with very clear guidelines. Some of the technology that we've piloted already has notifications within those Wi-Fi blood pressure, where if, for example, their blood pressure is out of range or their weight is out of range, they get a notification from the nurse practitioner that, hey, today you are 2 pounds overweight. What's happening? Did you take your medication, or what did you eat? So I think there are ways where we can do that for example, in heart failure to reduce readmissions. Another area where we have challenges with patients that are taking Coumadin, either for a heart valve or for a stent. And many a times they have to measure their INR. And sometimes they may have taken a dose which may be too much or it's too little. And they show up in the emergency room either with a bleeding episode or with an INR that's 5 or 6. That's way above the therapeutic dose. So again, there are ways where we can leverage technology, to give them reminders as to when to take the test, or call when if you do the test and your INR is above 3, give us a call. And then lastly, one which I think is quite common is atrial fibrillation, for example, right? So many people are walking around with atrial fibrillation, and they identify that their pulse is fast, and then they panic, they call, and they show up in the emergency room. So here again, we're using devices that can actually, even the Apple Watch can do that. You can record your own EKG over 30 seconds or a minute, and then send that strip to your physician or to the nurse practitioner that can look at it and give you a quick, oh, don't worry, or come to the ER, or take an extra dose of a beta blocker. So there are ways to do that. The challenge though is how to implement this, at scale. And to do that, one of the challenges I think is the data sharing portion of it, where people have, there are different platforms being used, and there's not much interoperability between platforms. So that's one. And secondly, our system is, our health system has been geared where, hospitals or physicians keep the data and not the patient, right? Whereas in Europe, I think it's the other way around, where, patients are encouraged to keep their own patient data. So I think to the point where that remains the scenario, there's always going to be gaps in terms of, data sharing.
I can really see that and appreciate that. Eduardo, would you like to weigh in on this one in the context of what you have seen in practice, and also maybe in some of the prevention models that are being introduced, and how we may be able to apply those in the context of patient readiness as well as clinician readiness for adoption and scale of such programs?
Yeah, Fran, I'm going to go in a slightly different direction if it's okay, just because we're talking about technology, and we talked about social determinants of health on the front end. And so one of the realities for patients, for all patients, is that there are non-medical issues that can play a role. And those can be issues related to housing, transportation. I mentioned transportation earlier for both of my patients. Food insecurity, I think we mentioned earlier. And so what I want to add to the conversation, and believe me, I think readiness is so important and so understated. And it comes back to the issue of digital literacy and health literacy. That's digital literacy and health literacy of the patient's home in some ways, and then not only of the clinician, but the clinical care setting and the clinical care team. Because at the end of the day, these technologies have to be thought of in a team-based kind of way. And so I think I would add that one of the challenges right now is that we did go from 0 to 60 during the pandemic. But one thing that we didn't figure out is how does flow that we can imagine exactly how it works when you go to the doctor's office. You sit in the waiting room. Well, actually, you walk in, you go to the receptionist area, you sign in, you sit down, somebody reaches out and says your name, you walk in and sit down. It's just like when you get on an airplane. Everything that happens is entirely predictable. We don't know that pattern for a office, for a tech based office visit. We still don't know how to do that flow as well as we could. That's an area of research. But let me go back to my digression, because I digressed from the digression, which is something I do.
No, you're right on target. Keep going.
So the thing is that patients who come in, one of the other things is that what's top of mind may not be my blood pressure control. We got to figure out how to make that just a normal everyday part of life on the one hand, but also be able to assess and address the thing that is getting in the way of that person living their best day, their best week, their best life. And so we've been in contact with some social care technologies, some social determinants of health platforms. I'll mention two, just because they're kind of they're the CVS and Walgreens of that world, and that would be Unite Us and Find Help. And the opportunity there is to use technology to not only connect people to the services they may need. And, you know, federally qualified health centers have had social workers forever. But what social workers have not always been able to do is to track and monitor what is going on with their patients. And systems have not been able to track and monitor and figure out the analytics that might help get additional insight. So I bring to the table the opportunity to leverage technologies to also address some of these social needs that are a function of social determinants of health and might help us achieve the success that we're trying to achieve clinically by addressing all the things that are getting in the way of a person achieving that health outcome that we want.
I think those are brilliant remarks. And I saw, Anne-Marie, you were nodding a little bit. Please, do you care to comment, maybe add a little bit to Eduardo's remarks there?
Well, I like the reminder that it's not just the patients that we need to be educating, but also the providers and the healthcare team. And we also need to be able to guide our patients to the right resources. The UK NICE system has a really nice list of sort of reviewed digital technologies that are, you know, good for, you know, your health. Meaning, you know, if it's a blood pressure monitor on your smartphone, it's been shown to work. If it's giving diet advice, it's good advice. I think, you know, from our standpoint at the Heart Association, I like that we're able to do some content embedded. You know, there's a lot of apps and things out there that are telling people to take supplements and eat weird diets that are not heart healthy at all. We need to help our providers and you know, our doctors and nurses and nutritionists sort of know what we should be recommending or not, but also some basic stuff. Like I think most people don't know that, you know, there are many cell phone companies have reduced price cell phone plans for people over the age of 55. T-Mobile, for example, has a big discount for seniors, which they start at 55, which I think many would push back on that particular designation of senior. But you know, there are ways that we can help our patients have better access to digital technologies. You know, even things like helping our patients sign up for their EHR-based portals and telling them, hey, you can schedule a visit with me and you can see your labs and I can communicate to you via that portal. So, you know, I like the reminder here that this isn't all on the, you know, the patient's side in terms of their responsibilities. Our health systems need to do a better job at getting out, you know, the messages around, you know, what's available, and our physicians need to have better support and resources that we can use to guide our patients to the right kind of tools to make their lives better.
I think you're so spot on with that. You know, there had been prior to COVID and continues now the sort of controversy even around, you know, patient or personal, you know, generated health data and, you know, clinicians' readiness to be able to have conversations with patients as they do elect to be more involved in their self-care. but also too, this readiness for clinicians around the utilization of data science as a whole. So Reach, we do quite a bit of research, and in partnership with Ipsos Mori, one of the big data points that came back most recently, and the digital doctor survey that they conduct really showed that clinicians feel that they don't have enough training to really feel confident. And I think it's important that we level set that while there was a huge uptick that we saw during the pandemic with the utilization of telehealth and other tools, the reality was that it only represented 30% adoption. And there were so many and continue to be so many areas where it could be utilized. And much of what we call telehealth was actually telephone. Don't know that it really matters, but the notion that we are now sort of extending care in ways that reach individuals. So Jack, I'm wondering from your perspective, particularly as we refer to the clinical appropriate application of digital technology and preparing clinicians for this, what are some of the things that you believe are missing or might be needed to make sure that the whole of the healthcare profession is better prepared to do sort of the things that Eduardo described, which is creating for more refined a clinical flow that takes into account digital technologies?
Yeah, I mean, I think this is a loaded question. I think that's where we all aspire to, but I think there has to be a fundamental shift to the thinking, because as clinicians, the traditional model, as patients come to see you, you take a good history, you examine them, prescribe some pills, and you expect things to fall through. But when you start looking at digital technology, data science becomes a very big part of it. And I think most health systems of today who really want to go into the next gen of digital technologies, predictive analytics and all that, will have to make sure that they have data scientists as part of the core team of developing these technologies. Secondly, we have to leverage implementation science to some of these new tools. For example, if I'm giving someone a wearable to measure, to go home and to get an EKG and to come up with a diagnosis, and I'm using AI or machine learning to make that diagnosis, I've got to make sure that that AI is reliable. I've got to make sure that the AI that was built off the data set represents real world data. And many a times, a lot of these tools, the AI tools that are being built, unfortunately, were built off data sets that are not diverse. So we have sometimes some of these data sets, you look at the data and it's maybe 95% Anglo-Saxon, or maybe 2%, African-American, 3% Latino. That data set is not applicable to real world data. So we have to be very careful how we're going to leverage these technologies, how we're going to implement them. And I think it's going to be up to us to make sure that when we design those workflows or those clinical pathways that are going to leverage digital health technology, that we make sure that that there is some ethical basis for designing those studies that makes sure that we are including we are having as much a diverse pool as possible, such that whatever that predictive tool ends up being, it is applicable to real world data. So that's, to me, is where I think there needs to be building of teams of clinicians, data scientists, social workers, community health workers. We all have to be in the same room, and we all have to think through the process or the ideation process through which you build the technology. And then we have to implement that through some form of pilot. And then if it works, then we scale.
I'm going to jump in because Fran's been telling me to jump in, but I'm a biomedical engineer by training as an undergraduate. And then I went to Duke University and studied some more biomedical engineering. And the truth is, Jock, I couldn't agree with you more. And I think that this notion of team-based care has to extend beyond just people who are clinically trained and has to extend beyond our notions of these walls that we've kind of created figuratively and literally. So I've been a believer for a long time that some of our public health and healthcare challenges could be better addressed than we're addressing them now by bringing systems engineers into the conversations that we are having about how we organize care and how we deliver some population health stuff versus individual health stuff. But I also couldn't agree with you more that data scientists are important at every level of health that we're doing. Public health, population health for sure, what's going on in clinical care, but not only what's going on in clinical care, but at the different levels, at a health system level, at a individual clinical care level, at a hospital level. And I also couldn't agree with you more that we need those systems engineers and data scientists in the room as we take artificial intelligence or whatever it is that is actually a predictive analytic tool and refine them as we test them and use them in real world settings and use the same ability of that artificial intelligence to be smarter about who it serves, to be smarter about the new data that comes in. And we say that, but we don't always do that. So I could not agree with you more that we need multidisciplinaryism to be the mantra of how we go forward to improve the health and the delivery of health for people. One more thing to add, let's make absolutely certain that we are bringing, I think to the point that you were making, Anne Marie, we need to make sure that diversity and inclusion is one that is not just about who's at the table with degrees, but who's at the table who actually lives the real world experiences so that they can remind us, hey, that's not going to work in our community, or hey, that didn't work in our community, or hey, that did work. And that's the sort of thing that we ought to be doing in English and Spanish and Mandarin and all the different languages that are the languages spoken by people in their homes and in their communities.
Another vote for violent agreement on all of this. I do think, though, there's a lot of people have gotten overly excited about, AI and machine learning and fancy risk prediction and genomics and personalized medicine. And there are some applications, I'm a preventive cardiologist. I try to keep people from getting heart disease. And for 99% of the conditions in people that I treat, I don't need a fancy algorithm or a risk model. If your blood pressure is over 140 or for a lot of people over 130, we need to bring it down. And I don't need a risk model or artificial intelligence to tell me that. If you have risk factors for heart disease or evidence of heart disease, you should be on a statin and get your cholesterol down. And that's easy. The hard part is actually not the modeling. We don't need, for a lot of these things, new models or, fancy trackers or some genomic home testing. What we need, as Eduardo's mentioning, is systems changes. How do we find the people that have fallen through the gaps? How do we nudge providers who have sort of forgotten about somebody's blood pressure or their cholesterol medications, or maybe somebody was intolerant to statins, but we have a bunch of new medicines now. How do we get them back into the game on these things? And that's where we need to be thinking about using our digital technology to try to innovate on the processes and not just get distracted by the latest algorithm or or new piece of thing, new data thing that we can measure, heart rate variability or something like that. Like, let's start to fix the things that we can measure easily, like cholesterol, blood pressure, diabetes.
Totally in the camp of tackling the low-hanging fruit of it, right? But when we think about things like the number of patients that are needing to have support, when we look at the, the percentages of individuals that are, that have chronic diseases, in particular heart disease, which is, since it's the number one represented, the volume of patients, the diversity of those patients being, it's many of them in places where there are deserts, where there's, where there aren't access to specialists like yourselves. This is where we see the opportunity for the technology. And I know, Jacques, you're nodding on this. We see this here in the United States. We work on these problems in other places. I think about, populations in the Tiwi Islands that I've, worked with, and that becomes a real challenge equally, where we're seeing changes in their lifestyles and the need to address these issues. Do you care to comment a little bit on that?
Yeah, no, I think as far as I'm concerned, the role of digital technology is to increase access and delivery of care. That's ultimately what we want to do. And so you find out in a lot of places, access to basic diagnostics, for example, having an echo, a cardiac echo, or having an EKG done. I'm not just talking about the US, but I'm talking globally. And that's not available, right? So, a lot of my research work is on leveraging some of these tools. Could you have a very low cost ultrasound probe connected to your phone? Could you do your own, could you do your own heart scan, or could you do a maternal fetal scan just to make sure that the baby is alive? So those are low cost technologies that, if we put them in the right hands, and by that I mean they don't have to be clinicians. You could train, a mid-level, a nurse practitioner, a community health worker how to do a scan. So I think that having low-cost, scalable technologies could help increase the diagnostic yield, figure out those patients that have heart failure, figure out those patients that need extra care, and then refer them to the appropriate, specialized centers for more advanced care. And then those that don't need, they could be managed, in the community, by a mid-level or by, a nurse or a nurse practitioner. So I like to see the role of technology. And I know Anne-Marie said you don't need all these sophisticated AI tools, but I think getting this technology down to the point where it is easily available, everyone in their home can have, basic blood pressure check, basic oxygen saturation check, can walk their, 2 or 3 miles a day, measure those metrics, and use those metrics to improve their lives. I think is where we need to be focusing on.
Very fascinating. So Eduardo, do you see this showing up in the way that we create for new programs and execution? And I also, before you answer it, like to encourage any questions from the audience as well. If anyone has any questions they'd like to pose, so please put those in the chat window. We'll make sure that we get to those. But just going back to you, Eduardo, any thoughts on this idea of how do we implement it in terms of the models and the relevance of those models or value of them today?
So absolutely think we need to implement them. I think the kind of research that Jacques is doing, the kinds of things that the Center for Health Technology and Innovation is trying to do, some of the work that you're doing is work that we need to rigorously, robustly, but pragmatically evaluate and then iterate and keep trying to learn. Again, sort of the violent agreement. I just can't agree more with what's been said. I do think that figuring out how to, I think the example of community health worker with technology is actually a statement of high touch and high tech. So you don't need that clinically trained person to necessarily be the person in the home, but you need somebody who's trained well enough to be there, who can do the eyes and ears look at. I don't know about you, Anne Marie. I don't know about you, Jacques, but I did home visits. And oh my gosh, the kind of insight that you can get with a home visit. Now, did I need to be in that home? Not necessarily. In this day and age, a community health worker with a camera can provide all kinds of really, really good insight into whether what we thought was the situation for chronic disease management, or better yet, for surgical wound management, is or is not what we thought it was. And then we can augment or subtract from what it is that we were planning based on what we can see. So I believe that there's all kinds of opportunity. I think we need to be realistic about what we're trying to do. We need to be rigorous about evaluating what we do, and we need to continue learning and figure out models that allow this to be supported. I think that's the other thing. When I say models, I'm talking about reimbursement so that this can work. We live in a country where you got to pay for it in order for it to be done. And we're still struggling to figure that out. And we can't make it so hard to do that the juice is not worth the squeeze.
Mm-hmm. Excellent points. And I think, combining that with what Anne Marie remarked on is equally important, right? Don't wait, get started, move now. There's a lot that can be done with what we have at our disposal today that we're just not appropriately, not leveraging to the extent that we could. If you would, Eduardo, talk to us a little bit about what the AHA is doing with the FQHCs and the NHCI program.
Absolutely. So I'll say it because in the context of the conversation we're having right now, it connects to lots of things we've talked about. One is the disproportionality that COVID had on certain populations due to a disproportionate burden of social determinants of health factors, a disproportionate burden of cardiovascular disease risk factor that played out as really, really bad outcomes with COVID, either severe or fatal. And the idea is to address blood pressure control. Hypertension is one of those risk factors, and using technology, self-measured blood pressure devices, fancy way to talk about home blood pressure devices, and put them in people's hands. But what we've come to realize is that connectivity is really important. Being able to do the EMR interfacing, being able to do the interfacing with apps or remote patient monitoring, critically important. But also part of this project is about assessing and addressing those social determinants of health, because whether it's the COVID times or not, there are burdens of risk around a whole host of things that are worth addressing once you've assessed them. And these technology platforms are the way that we're going to do that. So this ties in really nicely to how one uses technologies in a way that improves health outcomes and reduces disparities in health. So thank you for the opportunity.
Excellent. Well, thank you so much for sharing it with us. I always like at the end when I do these panels to give folks an opportunity to reflect on maybe a tool or a resource or program, something that they have found invaluable that they'd like to share with others. And I'm really grateful, Eduardo, that you were able to share about the work that you're doing for the NHCI. Anne-Marie, would you also we're about to wrap up here. Do you want to take just a moment to share with us perhaps a program even that you find is a valuable one that we perhaps could learn quite a bit from?
Well, I guess I would, the first thing would be just to let people know that there's a lot of low cost smartphone, either prepaid and postpaid plans out there, including for older people, but also for younger people who don't have access to internet, that can help people have access to a lot of those tools. And then one of the best technological innovations that that we use all the time to help our patients is Goodrx.com. It's a website that you can use to find what the drug prices are for any of the medications that you have. Oftentimes, even if you have insurance, it's cheaper to pay the cash price at certain pharmacies. And you'd be shocked that at a Walgreens, it's $60 a month, but at Harris Teeter, it's $6 a month. And so I use that often to help my patients find where the medications are cheapest, and there are coupons available there. So those would be probably two digital resources that I would advocate from this team.
So my remark to you on that would be, we're all going to run to that again. We are right that we all have.
I use it for my prescriptions because it's like $20 is like $20
exactly.
you get back in your pocket.
It's really not an us and them, right? We're all in this, and we can all benefit from those savings. Thank you for sharing that great resource. Now, Jacques, you have recently published a book on cardiac surgery and global health care. You want to tell us a little bit about that just really quickly in this last couple of seconds here?
No, yeah, so thank you. Yeah, so I mean, this work is kind of just following on my passion for, addressing cardiovascular health disparities globally, right? So, I mean, we are a global village, and then there's 5 billion people that don't have access to surgery. I mean, believe it or not. So this book was just, collecting different ways to capacity build, both from the surgical standpoint, from the cardiology standpoint. And there's a big portion of it that talks about how we can leverage digital health technology to improve access to, cardiac care, as well as delivery of cardiac care. So it's a combination of some of my research work, as well as some of the more than 40 authors that contributed to it.
That's excellent. Well, thank you so much. Well, I think that if we take from the last remarks and even the beginning remarks, we can see that there is lots of room for opportunity, for improvement, but also the recognition that there's so much that we can do with the resources that we have at our disposal today if we only take the time to take advantage of those. And that includes in delivery of the care that we provide to our patient populations, but equally as we consider our practices, again, whether those practices are within research or directly within care delivery or prevention. I'd like to again thank the American Heart Association for affording us this opportunity to discuss such an important topic. And thank you to our panelists for your excellent commentary, and to our participants as well. Have a wonderful rest of the day.
Thank you.
Thank you, everybody.
Thank you.
I think we'll get to stay behind for a second, or is everyone dropping?
I'll stay on for a second, Fran. When you mentioned the border, I got goosebumps because when I was the director of the state health department, which is something that I got to do for 5 years, the sister cities was something that people don't even know they exist. And one of the things that we were working on before the really bad stuff started happening with the narco trafficking was that we were working on preparedness programs where, if you think about all those sister cities, the bulk of the population is on the Mexican side. The bulk of the resources is on the Mexican side. And we were figuring out how in time of an emergency, if you're in Brownsville, Texas, and something happens on the Brownsville side, Matamoros may be the place that you need to try to get to, and vice versa. And all of that fell by the wayside. And then last thing is that I was working on a program because there are so many undocumented people in Texas and in the United States. I was working on a program through the Ventanillas de Salud programs and the embassies and the consulates, where persons who were Mexican nationals who needed specialty care, around which there's such a pain point in this country to provide that care, that they would get telemedicine care in the consulates in a designated room. The consulates would set up Class D pharmacies to be able to dispense drugs, And in essence, Mexican nationals would be getting care in Mexico, if you will, and not be a burden on whatever. And you know, things just got in the way. Time sometimes can be your enemy. So
time can be your enemy. I spent a lot of time, you know, I worked with Ushumba and the Pajo. That's actually where I had pretty much started my career in public health. And at the time, you know, HIV/AIDS was, you know, was the epidemic at that time that we were grappling with, and trying to create community planning groups to try to address many of the challenges that were occurring. And you're right, even equally in terms of how do we share resources along the border to make sure that individuals had access, whether they were documented or not. And examples of what you were describing were, you know, very much similar. It's the real work, right? It's the real work that that we have, that needs to be done, and that some of us choose to do. But in doing it, it gives you a different perspective on what's possible, and you know, it can be sobering, but it also can be it can also open you up to be more opportunistic in recognizing where there really is opportunity to do more with what we have. And you know, the notions of the promotoras and community educators and social workers and all these other multidisciplinary teams, professionals, are really critical to being able to extend that care and delivering it into the home. And you know, providing the technology is fantastic, but it's, you know, it needs to be hybrid models, in my opinion. And that we, yeah, right?
I completely agree.
Yeah, I could talk with you forever.
Yeah, I know.
I can't wait to have a chance to chat more.
I totally agree with you. I'll share. I see we're recording, but I'm going to share this anyway. So back in the day, you know, you got to do what you got to do. There were situations where on the other side of the border, we would hear of, because my counterparts, I had 4 counterparts along the U.S.-Mexico border, on the Texas-Mexico border, 4 states. And I would get a call from one of my counterparts that there was a person with XDR tuberculosis, extremely drug resistant, $10,000, $100,000 treatment. What we used to do, Fran, is we used to smuggle drugs into Mexico to take care of patients. We just, taking care of that one patient was going to protect the rest of the—
protect the border, protects hundreds of lives protected. Right?
Exactly. So I was in the drug smuggling business, smuggling tuberculosis drugs into Mexico. I wasn't doing it. I had others, there were others doing it, but we were just trying to meet people where they were and take care of them. And it didn't matter what side of the border they were on.
Well, that's the element, right? And I don't know how much we learned or didn't learn during this, you know, communicable disease pandemic. But that's the reality. You know, disease knows no borders.
That's right.
No borders. So
that's right.
Yeah.
So Fran, I look forward to chatting with you in the future. Doing more. And thank you for what you do, and thank you for hosting this.
Oh my goodness. Thank you so much for being with us. Such a pleasure to meet you, Eduardo. Take care. Have a wonderful evening.
See ya.
Bye. Bye to anybody else who's still hanging out there.